I'm just going to talk about coronary CT because that is the main thing you guys are going to be ordering it for. And then maybe later we'll talk about like other applications of cardiac CT. So this is going to be mainly at like the first and second year. So Bill and Kashan's not here. Guys who've gone through CT, and Kashan's there, may find it a little bit basic. But you know, this will be a good introduction just to cardiac CT. So as most of you are not too familiar with what happens in a cardiac CT, right? From where I came, we never did this. Anybody had CT experience, like ordering it as a resident? Okay, so I think this really is the most important thing. So what's the difference between a coronary CTA and a non-cardiac chest CT like PE? And Kashan, you're not allowed to answer. And Bill, neither you. Gating, okay. So coronary CT is gated, and we'll talk about what gating means. Whereas a chest, like a PE, is not gated. What else? Exactly, yeah. So it really depends on how you time a contrast bolus. So you're going to give a contrast, and you can image at different times. So for a PA, which you're imaging for a PE, you're going to image quicker, and then it's going to transit through the heart and come to the coronary, so you're going to image later. So that's why a lot of the times they're just not well opacified. Any other differences? So those are the two big ones. The breath hold. So for a chest PE, there's still a breath hold, I think. But I know for the lungs and stuff, you know, I think they do still ask them to hold their breath, Ryan, unless you know for sure, because I'm not sure now. Okay, yeah. Heart rate. So yes, we will control the heart rate for a coronary CT, and by that, what you're doing is increasing the temporal resolution by slowing down the heart rate. So we'll do that. And last thing, small thing, is we give nitroglycerin for coronary CTs to vasodilate the coronaries. So once in a while, actually, when you can see the coronaries on a PE, like the timing just happened to be in a way that there is contrast there, the vessels still look pretty small because they haven't got a nitro, whereas a coronary, they look much bigger because we give nitro. Okay, so we talked about this. So in general, you know, there's different ways you can evaluate CAD, and you guys are going to get familiar with most of this. And for me, the hardest thing, you know, during fellowship was realizing which way to send a particular patient. So you can look at anatomy with CT or cath, or you can do all kinds of stress tests, which, you know, all of these are in general going to give you the same answer. You're going to get the same answer from here. And then our gold standard right now is FFR, which at least right now we can do by cath only, but soon we should be able to do that with CT. So I like to just sort of, you know, think of it this way, and then each of you during training, you're going to get your own biases about, I prefer this test over that test, and that's fine. You know, there's no wrong answer here. But there's certain nuances to like which patient I think works better with which one. And then, so I guess, you know, how I really look at CT is it's like a poor man's cath. So, you know, you think a patient needs a cath, but you think it's going to be normal, you know, that's going to be a CT patient. And you'll figure out over time, like which way you want to go with particular patients. Okay, so outline's going to be, so we're going to talk about the scanner a little bit. We'll talk about, you know, which patients are appropriate for a CT and how you prepare a patient. So as you're ordering a scan in clinics or what to think about, we'll talk about the actual scanning, what happens there, and then what happens sort of behind the scenes with image reconstruction and post-processing, which we do on our monitors when we are reading. A little bit about dose reduction. This has been the big thing that I think cardiologists have contributed to, and I care about this a lot as we are scanning. We try to minimize the radiation dose that a patient gets. We'll touch on what the evidence for CT is in a usual run-of-the-mill patients, which is going to be stable chest pain. Very briefly about CT in the ED. I don't think we come across this much. I think the ED usually does that. And then triple rule out. And then new frontiers, which is CT-FFR. There's certain things you can do with plaque characterization with CT, which are still sort of in the early stages, but we'll touch on that. And then if we have time, about guidelines. Okay, so this is a basic, just a diagram of a CT. So you're going to have your, so this is your gantry. Oh, this is touch screen. I keep forgetting that. So this is your table. Your gantry is going to be around here, and then you have basically a X-ray source, and then on the other side you have detectors. So sort of same as your CAT. You got your II and your X-ray source, and then this is going to rotate around the heart, and then the table is going to move depending on the kind of sequence that we use. So, you guys know that CT has gone through many iterations. So one row means, how many rows depends on like how many detector rows there are. And it started off with, I guess the first one was a single row, but now we are up to, the one we have here is 128 rows. And I think we are soon going to get the 320 rows. So that's sort of the state of the art right now. So you'll see as you go through your temporal resolution increases, and we'll talk about that a little bit, what that means with the resolution. Spatial resolution, all of that has gotten better. But I think one of the more important things is the volume you can cover with the rotation depends on how many rows of scanners there are. That's how much volume you can cover. And that has increased as the number of rows have gone, and that means you need less scanning time, so less breath hold, and also you're radiating for less time, so there's been a massive dose reduction as the number of rows has gone up. So volume covered with one rotation of the CT is going to be, number of detector rows by detector width. Detector width has stayed the same, and you can see now with 64 rows is sort of all the trials and stuff. Those were 64 detectors. So you get like 4 centimeters of coverage. So usually it's 2 to 3 heartbeats that you cover the whole heart with the scan. Any questions so far? So just quickly about single source versus dual source. Sort of self-explanatory. So the one here we have is 128 slices, but it's a dual source. So there's 2 sets of scanners. Each one has 128 detectors. So what happens with that is normally it needs to move 180 degrees to cover, and now it just has to move 90 degrees. And somehow with this, the temporal resolution halves. Okay, so, in CT, we really depend on, so what CT is basically doing is it creates an attenuation map, and that depends on Hounsfield unit. So Hounsfield is the guy who invented CT in the 70s, won a Nobel Prize for that, so this is named after him. And you don't need to know these numbers, and most of this stuff makes sense, that, just sort of what Hounsfield level there is to different things. So you can see stents and coronary calcium have a lot of attenuation, so they have a high Hounsfield number. That's why we give contrast, because without contrast, you can't really tell between a vein or a, you can't even touch it. This is like, yeah. Hold your breath. Huh? Hold my breath, yeah. So that's why we give contrast, because between like a vessel lumen and myocardium, it's sort of the same Hounsfield units. And we exploit that by giving contrast, which as you can see, that increases your attenuation, so you can really tell the lumen. Just briefly about, you'll hear about like DLP and millisieverts. Those are sort of radiation terms that we talk about. So radiation dose is now the standard that we use is called dose length product. And that's like your actual radiation dose that was given out. So you don't really, I think, need to understand like how they get to that. But that's like your actual radiation dose. But then we calculate something which is effective radiation, which is your DLP multiplied by tissue weighting factor. And this varies for what part of the body you've scanned. Okay, so it's going to be different. And that's basically what they're saying is that is actually what is absorbed by that organ. And that's different depending on what you scan. No, this is how much actual radiation was absorbed by the chest if you radiated the chest, which is going to be different from if you use the same radiation to scan somebody's abdomen, and it just absorbs different. So what is sort of the harm you're going to get? And that weighting factor for the chest is 0.014. You guys don't have to remember this, but that's how we get our millisievert value finally. Okay, so back to gating. So why do we need to gate? So on top, what you see there is the motion of coronaries throughout a cardiac cycle. And as you can see, coronaries are moving. And you see this on CAT too, right? When you're doing CAT, you can see them, they move quite a bit. RCA probably moves the most out of all the vessels, and you've seen this on CAT. And that's RCA is sort of what we struggle with on CT too. And as you can see here, there are two relatively still periods for coronaries. So one is going to be your diastole, so closer to your E wave. And that's, as you can see, it's closer to like 70%. So this is your RR interval. We divide it into increments. And that's 70% of the RR interval, which is where we do most of our coronary scans. So that's because that's when you have the highest chance of finding the coronaries without motion. This depends on what the heart rate is. So that is ideal when the heart rate is on the low side. If somebody's tachycardic, the best chance of finding somebody's coronaries to be without motion is during this other period, which is at 40%, so end systole. Okay? So gating, what you're basically doing is you have your EKG on, you're acquiring images. So let's say you're doing retrospective gating, which is what all the coronary CTs used to be, and this is what we do in MRI too. You're taking pictures, and the scanner knows what picture you took at what RR percentage of the RR interval, multiple heartbeats, and then it stitches, okay, this was at 10%, the next heartbeat, that's what I took it at 10%, and that way you can stitch it. So it's sort of a way to freeze cardiac motion into a particular time frame, and then you sort of stitch it together. Does that make sense with gating? Because gating is really critical. We do it for all our all imaging. Yeah. Go ahead.
By having having two cameras, does that help you see that
heart rate?
Heart rate?
Yeah, because it improves your temporal resolution. So yes, so before the scanners that they used in the beginning, you needed heart rate, really much lower. Yeah. So as these are getting faster, your temporal resolution is better. You can scan at a higher heart rate. So now we'll scan up to 70. Ideally you still want it to be below 60. So as your heart rate is higher, we can scan, but you also have to give more radiation. So we factor that in too. It does. And it's a very good question, and we'll talk about that. Yeah, so that really throws off the gating, as you would expect. Yeah.
So can you shorten that RR interval that like, let's say you normally want to grab one little section of it, or you want to grab as much as you can because then you need less heart, right? Like if you could grab it between 40% and 60%, you need less heartbeats than it goes from 40 to 50%.
Say that again. So if you grab 40 to 60, yeah.
Or is it just still frames that you're pulling? And you stitch the still frames together?
Yeah, so it is still frames you take, and you put those together.
Oh, okay. So then it doesn't matter.
And I think we'll get to what you're talking about. There are different scanning protocols, and that vary with how much of the RR interval we take. Okay, so we'll talk about that. But just understand, CT is gated, and the reason why we are doing gating is to freeze cardiac motion, so finally we can stitch the images together. And without, we wouldn't know what was acquired at what time, and you wouldn't be able to stitch them together. Okay, so I guess getting closer to, Stephen, what you were asking for. So if you see, so this is just a schematic representation. So you start from the top, okay? So during this heartbeat, the scanner acquired this part of the heart, okay? And during that time, so we will tell the scanner right in the beginning, that you are going to scan, which is radiate, and images are going to be created. Let's say between. This is so irritating. Somehow, yeah, the finger just wants to go there. Between 70 to 80%. Okay, so the scanner is going to move, and there's no radiate. So X-ray is off, as you can see there, and then it's just going to radiate between 70 to 80%. So you acquired that part of the heart. Okay, and now the table is going to move. So you come to the lower part. So the next heartbeat, actually, there was no scanning because the table was still moving. So right here, and then you scan the next part of the heart. Okay, and this depends on how big the heart is, how many scanners there are, how much volume you can cover. So you'll cover the whole heart between whatever, 3, 4, 5 heartbeats. Yeah.
It's all under one bolus, I'm assuming, but given
Yeah.
an older scanner, would we have to re-bolus for each injection?
No, you still have enough contrast, but you see, as you stitch them together, you see like the contrast density is different between the different 3 or 4 slabs that have been stitched together. Yeah, but it's still pretty quick that there's enough contrast. Yeah.
That's why sometimes you have to do the different bolus because of the contrast.
No. So it depends on, everybody's coronaries are moving at like different RR intervals. So you go through to see which one the coronaries were the most still in. Right. The contrast difference is not, it doesn't affect image quality. Yeah. Yeah, but. Yes. Yeah. Because you just increase your chances of cardiac motion, so then we'll scan for more percentage of the RR interval. So then we have better chances of catching the coronaries at some point where there's no cardiac motion. Yeah. Okay, so yeah, so how we reduce doses through the years. So one, we already talked about, as you get more detectors in your detector array, you can cover more part of the heart in one spin. So you're scanning less, and then of course your radiation is going to be lower just from that. Most scans before used to be done at 100 kV. So kV and mass stands for milliamperes, are sort of your voltage and your current. So that's sort of your X-ray strength, if you will. So that's sort of what the machine, the parameters we are putting in, and how much X-ray strength it'll put out. And all used to be 120 kVs, and we were just scanning at that, and you get really good images. And then some guy had the brilliant idea of, well, maybe we should give less power to the X-rays, and you still get good enough images. So they then started scanning at 100 kV and found out the images are still diagnostic. So now we will very rarely, and this will depend on like body size and stuff, if you need to penetrate more. Standard imaging is at 100 kV, and this just drops your radiation by like a factor of 2, at least. Also now most of the scanners are something called auto kV, which is, if somebody is being lazy and not putting in the lower kV, it'll just pick it itself. So that's what now the scanners will just pick a kV by themselves. I think it's, kilo voltage or something. Yeah, right, so it's a voltage term. Iterative reconstruction, this is image reconstruction not specific for CT. I don't understand it too much, but there's different kinds. Filtered back projection is what used to be there, and then it's some mathematical algorithm, and you do iterative reconstruction. It improves your signal to noise ratio, so you can give less radiation because you're improving your SNR. So that's been a big development. Auto tube current modulation is your milliampere, and that's again, this is automatic in a CT that it knows. Remember, it was turning off and turning on, so it already knows that. So it will regulate how much current it's outputting depending on how much you tell it to scan, versus having a constant current all the time, and that gives you a higher radiation. Prospective gating. So I guess we'll talk about gating in a second, but before, all the scans used to be retrospective gating, which is you're scanning throughout the cardiac cycle. And as we know, most of that data is not needed, whereas now all the scanners are prospective gating, which is you tell it that you're just going to acquire images for me a certain part of the cardiac cycle, so prospectively telling it, so you're just radiating much less of the RR interval. So that's been a big development for CT. Yeah.
Assuming that your R is regular, right?
Yes. If it's irregular, then yes, we'll go to retrospective. Yeah. So, and we'll talk about the different sequences in a second, but you're right. High pitch spiral, this is, I don't know if you guys have heard me use the term flash. So that's the Siemens name for the high pitch spiral. And this is where there's something called a pitch for a coronary CT, and depends on how quickly the table moves. So now they've, technology has improved to the point that the table moves quick and the gantry moves quick, that you can actually scan the heart in one heartbeat. And of course, you're going to have much less radiation with that. So usually with high pitch spiral, and we'll talk about that, everybody can't be scanned in that. A lot of things have to be in place for this to work. The doses are less than 1 millisievert, which is really low dose. So this was some data that I had collected during my fellowship. So just to sort of, this is like what nationally has happened. So this is data from here, Blues University, the other one Southdale. This is in millisieverts. So 2008, that's when radiology used to read them. Are there any radiologists in the room? Okay, because they love to give radiation. So this is when they used to scan, so you can see 20 millisieverts. That's for a study. Yeah, so that's how it used to be. So it was all retrospective gating, so you're scanning throughout the cardiac cycle. None of the other technological advancement had happened, so it's not all their fault. And that it used to be 20 millisieverts. This is actually when we started reading, about 2012, and you can see how the doses just fell dramatically. Went up a little bit over time, and I think that reflects how people started hearing about coronary CT, and you started getting more complicated patients, where you do need to give more radiation to get good imaging. No, this is only coronaries. Yeah, exactly. So not TAVRs. Okay, so a little bit about resolution. So this is an important concept to understand, and I don't know enough to really explain it in detail. But spatial is basically, how much distance do two objects need to be separated for you to pick it up, right? So this is important in echo, and this is really where CT wins over a lot of other things except CAT. And spatial resolution is 0.3, if you just remember 0.3 millimeters in isotropic. Now, what does isotropic mean? It's a 3D data set. So it's not just your X and Y axis, it's also your Z axis, sort of going through. And this is sort of unique to CT. So echo and MRI have decent resolution in your whatever plane you're imaging in, so your X and Y. But your Z plane, which is sort of going through, which you need to evaluate coronaries because they do lay out, your Z plane resolution is pretty poor. So they don't have isotropic resolution. So this is really for CT. It's the same in every plane. Okay. Spatial resolution depends on your field of view. So this will make sense like when you've done echo, when you zoom in, you improve your resolution. That's why we zoom in into valves and stuff, as we were doing with the appendage today. It depends on your matrix size. So this is something that's inherent to every modality. They have different matrix sizes. And so the best matrix size is for CAT, so that's why they have the best spatial resolution. MRI, the matrix size is for, I guess, something to do with how MRI works, is still not that advanced, so the resolution is really limited on MRI. And it depends on slice thickness. So as you increase your slice thickness, your spatial resolution goes down. That sort of makes sense? Okay. And then there is temporal resolution, which is how far an event needs to be separated in time for you to be able to tell apart, right? So that's going to be really good with echo. This is talked about in milliseconds. You don't have to remember a number. But for CT, this depends on gantry rotation, how quickly that's going to spin around. That's why dual source. It can spin around quicker, so you have better temporal resolution. So we can't control that, but we can control that with heart rate. That's why we try to bring the heart rate down as much as we can, and that improves our temporal resolution for CT. Yeah. So I try to put these numbers together. I think as fellows, this is important to know as you're choosing a modality, and depending on the indication, you can sort of go towards one modality or the other. So you don't need to remember the numbers, but this just gives a nice comparison. So CT, like we talked about, CT is never going to be as good as cath. So cath has a much higher spatial resolution, as you can see there. So CT is sort of a poor man's cath. Okay, so cath has a much higher resolution, but as you can see for CT, it's much higher than echo and MRI. And I don't know, we were just talking about this earlier. At least I felt, because you hear MRI is awesome, that MRI's resolution is good. So MRI doesn't win because of having a superior resolution. It wins because there's no artifacts that you see in echo, so there's no chest wall or anything coming in the middle. You see the heart as it is, and then you can do tissue characterization with MRI. So that's where it really goes. But it doesn't have a higher resolution. That's an important point to know. And as you can imagine, temporal resolution, again, much higher in cath, okay? But also much higher for echo. So that's why moving structures, right? You need temporal resolution. So they work much better with echo, and echo is much better than MRI. So that's why we don't do MRIs for like valve stuff or small tumors attached to valves, because they're moving too quickly, and we don't have the temporal resolution with MRI to visualize that. Yeah.
I noticed you didn't have Nuke up there.
Yeah, I noticed that too late. I guess it doesn't matter.
I know.
Yeah. But you gave that talk to Nuke. What is it for Nuke? Do you know what the resolution for nuclear is? I'll throw it back at you. Yeah, I can't. Yeah. Yeah, so I know it's not that good, but I don't remember the number.
I think it matters on the new scanner versus the old scanner.
Okay.
I just don't remember what the
Yeah, I don't. Okay, so this is going to be important. So patient prerequisites, what do you need to have a successful CT? Because it's not going to work on everybody. So patient selection is very important. So your heart rate, as I forget who was asking, needs to be not just slow, also regular. Because if your RR interval has to be constant. So this actually gets to be a problem in really young, healthy people because they have sinus arrhythmia. So the RR interval is varying a lot, and that's bad for CT. Okay, you really need a fixed RR interval. And exopy is just a killer for CT, okay, because then we just can't gate our CT, and you don't get good images with that. Make sense with the heart rate issue? And then you still have to penetrate through, right? So we do get requests oh yeah, patient couldn't get a stress echo, so we'll get a CT. Well, it's the same body that's going to attenuate, ultrasound is going to attenuate X-rays too. So our usual, so for me, below 250 is not a problem. Above 300 is definitely a problem, and between 250 and 300, it depends what the question is. If they really want to know, I want to make sure every diagonal is free of disease, you're not going to get that answer on CT. Also depends on where they put their weight. So, all we care about is what's in the chest. So if they got a big butt or, somewhere else, that's okay. They have to be able to follow directions. So you have to breath hold for this. So, your psych patient or whatever who can't follow directions, it's not going to work. Must be able to lay flat, and we have to get the arms out of the field of view. So this does happen. We get patients with like shoulder injuries, and they're in a sling. CT is not going to work for that. Okay. And this is important. So GFR, 40 is sort of a cutoff. And sometimes we will get requests for, patient has CKD, we don't want to cath him, so we'll do a CT. Bad idea. So CT, you have to give about 100 cc's of contrast, okay, because you're giving it intravenous, not into a coronary. And cath, as you guys know, you can get away with like 20, 30 cc, with biplane. So CKD patients, just cath them. Okay, so, as you're ordering, patients might ask you, like, what do I have to do? So you got to be NPO for a couple hours, and that's just because they're laying flat, and if they get nauseous with contrast, you don't want them throwing up on the table. They'll need an IV. It needs to be a good size IV. Heart rate has to be steady, and below 60 is what we target, but we will scan up to 70. We usually won't scan above 70. So we'll give a lot of metoprolol. So when I started doing CT, I was like, holy shit, this is, after this, when you get called on the floor, like the nurse is afraid to give like 5 milligrams of metoprolol. So we give usually 100 milligrams as a single dose. So this is, nobody has taken a beta blocker before, we'll give them 100 milligrams. And then IV, we will give increments of 10 milligrams. So we'll give up to like 40 IV in a matter of like 10, 15 minutes. And I've never seen anything bad happen. So after this, when you get called, you're like, don't call me for, can I give 2.5 of metoprolol? So depending on that, so even when, as you can see here, even when it's between 55 to 59, we will give them metoprolol. And the reason is, once they're on the table, we give them nitroglycerin, heart rate goes up, we give them contrast and sort of, discomfort with that, the heart rate does go up. So we want it to be really low by the time we get them on the table. Yeah?
Do you give the nitro, obviously, how much pre-contrast? Because when you contrast on its own, it can be a vasodilator. You give it a fair amount, like minutes before you give the IV.
Yeah.
What's your nitro time?
Yeah, so we beta block them as much as we can, and then we decide are we going to scan or not. And then we've decided we're going to scan, pop in the nitro, come out and scan. Yeah. So it's minutes. If somebody's having a lot of PVCs, we can use lidocaine. I haven't seen it really work that well. So usually with PVCs, it just doesn't work. We give nitroglycerin, and I told you how much contrast we give. Sternotomy wires, I haven't seen that be a problem. And what was the other thing? Breast implants. Oh, I can't remember having done a scan, so I can't speak from experience, but I think it should be fine. Because it's, oh yeah, and it works really well. So we'll talk about that. Yeah. Yeah, pacemaker can sometimes cause artifact in the RCA, as it goes into RV. So usually what we'll do is do a calcium scan and see how much artifact you're getting, and then decide based on that. Okay, so 3 things that affect CT quality, just to remember, is body size, heart rate, and calcification. Okay, so a lot of our patients have had like chest CT for some other reason, so usually I will look at that to see just how bad the calcifications are based on that, and then decide. Okay, so we sort of touched on that. So you got your patient prep, you've given them the medicines, the tech will practice the breathing with them so they don't Valsalva. And then you'll do your scout topogram, so you'll do a PN lateral, and based on that, you decide your field of view, okay, just to get the heart. And then we'll do a calcium score. So anybody who's above 40 and doesn't have prior stents or something where it doesn't make sense, we'll do a calcium score. And then people have different thresholds for deciding, like, how much calcium score can we still proceed with the, coronary CT. I think nationally 1,000 is acceptable cutoff. Some people are too, actually I think some of the Southdale guys will stop at 400. But I think nationally, most people agree 1,000 is, you should scan at least 1,000. When John Lesser was here from Abbott, he said the techs don't even call him for calciums calciums below 2,000. So they just scan for calciums of 2,000. There's certain nuances to, what you can scan or not. So I look at where the calcium is, how dense it is. So usually if I can see some lumen with calcium, I'll say go ahead and scan, because those are, in my experience, work out okay. Matt mentioned this, so we will then decide, what to trigger off. So usually it used to be time bolus, where we would give a little bolus, wait for the contrast to come into the ascending aorta, time it, and then put that in. Now we do it off what we call as just threshold, and you pick basically a Hounsfield unit, and I think usually we are triggering at 150, I want to say, and you'll put, region of interest in the ascending aorta, and contrast is pumping through. As soon as it hits 150 Hounsfield units, the scan triggers. Okay?
So you're giving a small amount of radiation constantly watching it, and,
Yeah, but it's pretty low.
Right, like a very
Yeah, a single like X-ray. Yeah. But yes, you are. Yeah. And then we'll choose a protocol, and we'll talk about the different sequences that we use after we've done all of this. You scan, then reconstruction sort of happens in the background, and that's your iterative. So now we do only iterative reconstruction. There's something called a convolution kernel. There's different kinds that affects your signal to noise ratio. Depends on if you're going to visualize a stent, there's a different kernel that you can apply. So the tech sort of does all of that, but I just want you to get familiar with the terms. And then they'll send over the images to us, and then we'll do the post-processing, sort of different ways of looking at an image, and we'll talk about that. Okay, so scan modes. So there's generally 3 scan modes we pick between. So just to get familiar with the names, there's flash, sequential, spiral, and we'll talk about all of this. You can see as you're going up, you're sort of scanning more. So this is for more challenging patients, and your dose goes up with each one of them. This is what used to be done with those 20 millisievert scans, which is spiral, no MinDose, and we'll talk about this a little bit. And this we only do when you need LV function, and you're basically radiating throughout the cardiac cycle, which you need to do if you want to assess LV function. So we'll do this only for our congenital patients who have a device and can't get an MRI. So when they need RV function assessment, like PET patient with ICD, then we have to use that protocol.
That's why you use like 20 milligrams?
No, because you've had the other dose reduction stuff come in. So usually that's still like 6 to 8 millisieverts. So it's not crazy, but not insignificant. Okay, so this is flash. So this is what I try to get all of my patients to, but the patient has to be almost perfect. So what does that mean? So those 3 things that we talked about: body size, heart rate, calcification. Same things apply. Heart rate has to be below 60 and must be very stable, and we'll talk about why. No stents. Calcium score, you can have a little bit of calcium, but if you got more calcium, you can't do this. And then the patient can't be too big. And this is basically your high-pitch spiral where your gantry is going to be moving really quick and the table's going really quick through, and you basically cover the whole heart in a single heartbeat, okay? But you only get one RR interval, so it's one cardiac phase images, so it's sort of one shot that you have. Yeah?
If you need a super stable heart rate, it's sinus arrhythmia for a
Mm-hmm. So that gets to be, so usually we try to get our younger patients to do this, right? You want to minimize radiation. But the really healthy ones have a sinus arrhythmia, and then we can't do this. Yeah. The nice thing with this is this eliminates any breathing motion artifacts, which is a problem because of the breath hold, because you're done in a single heartbeat. So you're sort of freezing, cardiac motion and breathing motion with that. This is our sort of workhorse sequence. It's called sequential, also called step and shoot. This is what I'd shown you earlier with you scan a certain part of the heart, then the table moves, you scan the next part of the heart, table moves, scan the next part. You're done in like 3 or 4 heartbeats, and then you stitch it together, okay? So this is where your patient's not like perfect. So either their heart rate's a little bit higher, or they have some calcium scan, it's a slightly bigger patient. And there you have sort of multiple cardiac phases. So you're just trying to give yourself some leeway for post-processing, and if you had cardiac motion at 60% of the RR interval, well, you have 65%. And usually you can visualize, proximal LED was moving at 60%, but at 65%, proximal LED was okay. So you can sort of stitch different parts and see the whole coronary tree that way. We'll set the scan window based on the heart rate. So this is sort of, the text already have these instructions. If the heart rate's below 60, then you're basically opening up. So that means, as you can see here, you're radiating and acquiring images 60 to 70% of the RR interval. As your heart rate goes higher, remember, the more still part is in systole, so we try to get that 40% in there too. So then we'll open up 40 to 70%. But radiation goes up with that too. And this is the older sequence, also called spiral, which is pretty similar to the first one, which was the flash sequence. So both are actually spiral sequences. So the table is actually moving and the gantry is rotating really quick. But in this, you actually open up to acquire much more of the cardiac phase. So this is when this will actually do when ectopy or irregular heart rate is an issue. Okay, and then we'll usually open up. So usually we'll say just open it up in spiral, and then the tech knows what to do. And this is sort of you have the most information that's been gathered and better chance at sort of getting all the coronary segments. Questions about scan modes? Yeah. You get an idea right in the beginning, like how they are when they come and you've given the beta blocker already. So IV metoprolol actually doesn't help much. So we usually know after we've given PO what the heart rate's going to be and whether they're having ectopy. Final call we'll make like after we've given all the IV and the tech's getting ready to scan, and then you look at how stable the rhythm is, and then you make the call. Yeah. So usually they just do it. Challenging patients, they'll come get us, and then we make the call. So this is when you need the function, and I think we are running out of time, so I'm just going to skip this because this we don't use for coronaries. Maybe, I was going to ask you guys this, but maybe we'll come back to this later. Flash? Okay, all right. So you guys, you were listening. Okay. So this is your perfect patient. You're going to flash this guy. And then usually you'll get less than 1 millisievert, which is great. Okay. I'll just scan this guy. So why wouldn't you flash? So you see, I said heart rate really has to be perfect for flash. So this is too high to flash. Yeah, so this really is going to be, except the heart rate, he's not that big and there's not that much calcium score. So you can't flash. So you go to the next, which is sequential. Okay. And those are usually about 3 millisieverts. So national average now for scans is about 3 millisieverts. Okay. I'll just scan this guy. Yeah, so that's an option. Put them on, sometimes we will cancel and we'll say, take metoprolol for the next couple of days and then come back in a few days. But if you got a scan. Right. And that's the key here is the heart rate is variable. And once it's variable, then you really need that spiral sequence. And, so radiation does go up with that. Okay. So just quickly about post-processing. So I don't know if you guys have heard these terms before. So you get your raw data, which is the axial stacks. Not very helpful because coronaries don't follow the axis as a CT does it. So you do something called MPR, multiplanar reformatting, which is basically you stack all the axial imaging into a 3D data set that we can then manipulate to lay out a coronary in its axis, not the body's axis. Okay? So this is still our sort of workhorse and where you get the maximum resolution. So if you really want to make sure you want to maximize it, it's a little pain in the ass, and we'll talk about why. This is what I usually start with, is MIP, which is maximal intensity projection, which is you take a data set, and whatever is the brightest, so if you take a 5 millimeter data set, whatever is the brightest point in that, that's going to fill up that area. So you can see how it will decrease your resolution, but it makes it easier to see because you can get a thicker slice. Actually, you can get a thicker slice with MPR too. But this is just a little more pleasing to the eyes than MPR. So we'll start off with MIP. We'll get a slice thickness of 5 millimeters, and then we are able to lay out the coronary in its entirety, because coronary is usually about 3 millimeters, and it moves maybe 2-3 millimeters to one side. So if you get a 5 millimeter thick slab, you can have the whole course in like one 5 millimeter slab, which we can chop up into. So with time, you just learn which way the RCA is going to go, LAD is going to go, and then you just chop that 3D data set into that plane and lay out the whole coronary. Volume rendering, we don't really use it, but that's sort of your 3D data set. It just makes pretty pictures, but we don't use it for diagnosis. curved MPR, same as MPR, just you've now laid out the coronary in its entirety, and I don't really find it that helpful, so I don't really use that. So I'll use MIP, look at the vessel. If I see a problem, then I go to MPR and look at that segment. So this is, so axial slide. This is your MIP, so you can see it sort of looks like a nice, easy to visualize picture. You see a plaque there. Stenosis, actually you can see plaque around it. I don't know if it projects nicely back. This is your curved, I guess this is a curved MIP when you've laid out the coronary in its entirety. This is your volume rendered image. When an image is really nice, then actually you can see it on the 3D data set too, but usually it doesn't come out that nice, and that just confirms it on the CAT. And another important difference between CAT and CT, CAT is still a luminogram. So here you can see that the lumen is compromised, but you can't see what's around it. And a lot of times on CT, you will see that the lumen is totally preserved, but there's a lot of plaque around it, which is important information, at least in your younger patients for like primary prevention. Just a quick word about window and leveling. So this is really key as we image our, CT images. You need the right window level. So just as an example, this is a stent. This is not window level right, so you can't see anything through it. As you're adjusting your window level, and you don't need to remember those numbers, you can see how now you can actually see through the stent, and you can see the lumen is totally preserved. So there are some general recommendations. The window level has to be your mean Hounsfield unit. Window width has to be 2.5. I don't even know these till I was putting this talk together. But as you're reading them, you will figure out by window leveling what is the right window level. So it's more intuitive than actually remembering a number. So this is how we report it. CT is not that good, so it's hard to give like an exact number as we give in CAT, like 30% or 40%. But so we just put it into broader bins. And I think it works pretty well with sort of no plaque, minimal, mild, severe. I think it works pretty well. And just like in CAT, any visual assessment is going to be, there's going to be false positives, false negatives there. So this is where CT really doesn't do well, is the moderate lesions, because some of those are going to be significant, some are going to be mild. Okay, how much time do we have? So actually, I'm going to skip through this stuff. Okay, so a lot of studies have been done with the cardiac CT, and the message is the same from all of them. So specificity, which is if you really want to know that does this patient have disease or not, sensitivity, or your negative predictive value, which is going to be answering that question, is extremely high. Okay, so CAT is the gold standard, 100%. The CT approaches 99%. So we won't miss stuff on a CT. It's just we overcall stuff. So that's why our sensitivity or your positive predictive value is not that good. I think here they give, so yeah, your usual negative predictive value, I think approaches like more 99% with your sensitivity. So we won't really miss stuff. And here they're quoting a specificity of 88%. I think over time it's gotten lower, just like as, the honeymoon period gets over. Does that make sense with where CT strong point is? So just to compare to other modalities, so, we'll never order a stress treadmill because of those reasons. It's a 50-50 coin toss. But stress test, so echo and SPECT, 85, if you just remember that number. With MRI, it goes up to about 90%. This is sensitivity, and CT is going to be 99%. So if the question is, I just don't want to miss anything, okay, then CT is going to be the right one. And where you think, oh, this guy probably has disease, but I really want to know whether it's significant or not, CT is not going to work well. Okay, so we'll just briefly touch on this. Did you guys hear about the PROMISE study? So I think it came out, earlier this year. So this was, and actually the part that I had to skip earlier was sort of comparing, there was data on how bad stress tests are in the real world. So there was a big paper, actually, let me just show that quick. Yeah, so this is, So for patients who were sent because of a positive stress test to a cath, only 38% had obstructive CAD. So we all hear about that stress tests, don't work as well, but in real world, they're even worse than what me and you see around here. So then, it was really like, well, should we be doing a CT on all these patients? So this was the PROMISE study, which was basically deciding somebody has some symptoms and they need ischemia evaluation, big study, and they got randomized to either having some sort of a stress test or a CT, and that's all they got randomized to. And later, whatever had to happen, the physician could decide, and then they look for hard outcomes later, that what should be your first evaluating test. And, it was like so many of the cardiology studies, like no answer even at the end of this. So there was no difference. So there was no difference if you just look at like hard outcomes, they followed them for, I think, 5 years or something, and there was no difference between. So it's not, whatever you choose, it's not like you're harming your patient, I think. So I guess it also depends on what sort of question you're asking, how quickly you want to know. But you're not harming your patient with whatever. In the end, they're all going to, figure out the answer somehow and do fine. This is why, at least in my younger patients, I do prefer CT to stress test. And that's because this is older data now from James Min, who was here earlier. So let's just talk about this chart here. So we know obstructive CAD is bad, and that's what a stress test is going to tell you, right? But it's not going to tell you about non-obstructive CAD. And this is what this data shows, that if you had no plaque, okay, versus if you have non-obstructive CAD, it does affect mortality over time. And this is information that a stress test is not going to give you, because it's not going to tell you about non-obstructive CAD. Even in non-obstructive CAD, as you go from very mild, so less than 30% stenosis, to mild to moderate, that affects your mortality too. So this is data that CT is going to give you. And this is not new news. We've known this from CAT, but now we have the data for CT with actual outcomes. Other stuff that CT I think works really well for is anomalous origin. So we'll get these referrals from cath lab, especially after they know it's anomalous, but they don't know what course it takes. So in cath, it can be pretty hard to tell, and on CT, this is really easy. So this is the right coronary ostium. So this is looks like a circumflex coming from the RCA, and you can see it's going in front of this is the PA. So it's a benign course. It's going anterior to the PA. And let's see here. Yeah, so this is, again, right coronary cusp, and you get your left main with an interarterial course, as you can see here. So this is your PA, not a pacified aorta, so between the two of them. So Justin was asking, so bypass grafts, actually, it works pretty well. So especially in the immediate post-op period, when you don't want to cath them and stuff, it works really well. So when would I get it on bypass? I guess if I don't care about like native, if I know the natives are occluded, and all I want to know is are the grafts patent or not, and I don't care about like distal LAD and stuff, I just want to see if lima is open. So grafts you can see really well. They're usually much bigger, right, than coronary, so those turn out really well. Sometimes we have trouble with where the lima touchdown is, if they've put a lot of staples there, because you get a lot of artifact from that. But if that's not the case, we can see grafts really well. Stents, if it's proximal, so if they're big stents, our cutoff is they have to be at least about 3 millimeters, then we'll do it. But as you get more and more stents, multiple stents, chances are you're not going to have a good CT. For left main, I think the trial XL or whichever one was going on, this was part of the protocol. So left main stents, this is well accepted, it works well. We can do this. I don't really like doing the triple rule out because it just feels stupid. Like you can't make up your mind, is it ACS or PE or dissection? But it can be done. So double rule out is really easy to do. So when you're looking at coronary and aorta, the contrast is on the same side. All you do is increase your window. So normally you're taking just this much. You just go up to the arch and you got your double rule out. For triple rule out, when you also want to look for PE, then you have to do 2 scans because your imaging contrast at different times. So you do your PE scan, and then you follow that right back with your aorta scan. Okay, so it's 2 scans. Same contrast bolus, but 2 scans. We're not going to talk too much about this, but just so you guys know, multiple trials have been done at looking at CT use in the ED. And actually one was out of Uma Valetti and some of the Minneapolis guys are on the CT stat ones. And general message is it works really well, no surprises because you need a high negative predictive value kind of test in the ED. And they followed them and there was excellent survival. We didn't miss cases. So it was great for ruling out disease or quickly triage to CAT. And there was some thought of that when they compared it to nuclear, that you save costs because patients are just, you have an answer much quicker compared to a nuclear. Okay, getting to the end. So some of the newer stuff. Have you guys heard about CT-FFR? Okay, you know how it works, right? Good, okay, because I can't explain it. But, so there's a lot of complicated sort of computational fluid dynamics that goes in it, but I just want you guys to know. So you just do a CT as normal, as you would, and then you basically send the data to HeartFlow in California, and they send you the FFR.
So weird. They have a way of computer modeling hyperinflation.
Yeah, so you don't have to give adenosine. If you figure out, you'll make a lot of money. Because the reason why we're not doing it is they have a subscription model, so it's not per this thing. You pay them a certain amount per month, and apparently it's high to the point that we can't afford it. And of course, you can't charge a patient more for this, so it's sort of some cost that you have to, I guess, just like FFR in the cath lab. But basically, you know, they've compared it now to invasive FFR, and it works pretty well. And no surprises, it improves your specificity for CT, right? So even with CAT. So, but now we have the data for CT-FFR. So that was the DeFACTO study. This was the next trial, and just increases area under the curve compared to visual assessment with CT, you know, significantly. So I think this, as the technology spreads, costs come down, this is really going to be just like FFR in the cath lab. So that's going to be great. Lot of, yeah.
You can also do virtual sampling as well.
Yeah, and sort of see how they'll respond to that and stuff, right? So there is a lot of exciting stuff that can happen with this. Lot of research being done on using CT for plaque characterization. So are there high-risk features there when you have non-obstructive CAD that can help you predict someone who's going to develop ACS? Sort of the holy grail of, you know, CAD. And so there've been small studies, you know, with sort of statistically significant results, but the, you know, numbers are still pretty small. So this is not, you know, ready for prime time or something, but just so you guys know, so positive remodeling, I'll report that. Easy to see, very reproducible, and that's just that a vessel tries to preserve its lumen. So as you get plaque, this is what coronary vessels do, that it spreads outwards. So it positively remodels, so you have a lot of plaque there, but your lumen is preserved till a certain degree, and then it starts to narrow. Low Hounsfield units, which is basically like, you know, just fatty deposits, and that's what fat has a negative Hounsfield unit, so that's what gives you the low Hounsfield unit, and this is what is your probability of developing ACS down the line, your relative risk. So the numbers sound pretty impressive, but it's still, you know, small numbers. Spotty calcification, so this I think is going to be, I don't know if any of you were at my calcium scan talk, but now we are starting to realize that all calcification is not the same. So because now we are finding out with statins, actually your calcium goes up, which doesn't make sense because we know statins stabilize plaques. So now we are starting to realize that calcification is different. And spotty calcium, which is you have like little calcium spots in the plaque, that's bad. That's a marker of unstable plaque versus just sort of your calcium score calcium, which is dense calcium, which we think is more the burnt out stage of the plaque, which seems to stabilize it. I think we'll just skip this, but I'll there are appropriateness criteria for where you can use CT, and the general theme is you want low to intermediate risk patients. This is not for high risk patients, and then you can do a CT on those. A very common referral to us is somebody had some sort of a stress test, echo and nuclear, and it was indeterminate, and then they'll come for a CT. Okay, so that is recognized as an appropriate use of CT, and then it is actually appropriate to use them if stents are more than 3 millimeters, as I was saying, and like I said, for bypass grafts, it works well. So this is the NICE guidelines, and I think this is probably what I do too. And as a general thing, I think it works well. So low risk, consider don't doing anything, as hard as that is. But your intermediate risk, if it's in the low to intermediate category, and those are just numbers, then do a CT. If you're going to have your sort of intermediate to high risk, when you think they're going to have disease, you just want to know whether it's significant. I guess stress works better in that. And if you have very high risk, then of course most of us go to CAT. And of course with the high risk ones, the CAT, we use it, or at least I use it more for prognosis. If you already know that they have angina, you don't need it. Or if somebody has severe symptoms. Okay, so just to summarize, so CT has excellent negative predictive value versus any stress. Remember, stress is about 85%. MRI goes to about 90%. CT, you're going to get 99%. Low radiation, as opposed to like SPECT or CAT. Okay. You get the non-obstructive CAD information. So your young patients, you're like, well, okay, you don't have obstructive CAD, but maybe you need a statin or something. So you get that information. And then versus CAT, you're getting your plaque characterization, your positive remodeling information, which can look totally normal on a CAT, so you get that information. Limitations are poor positive predictive value. So this is where really CT suffers. So if you have your moderate lesion, it's sort of hard to tell. I think if you spend some time on the scan, which I like to do, I would like to think, at least so far, I don't have too many false positives, but your usual busy places where they're reading a lot of CTs, they'll just call it moderate. And most people, once they get a result with a moderate plaque, they'll send the patient to a CAT. Calcifications, that is limiting for us, and stents, usually, it doesn't work that well. Okay, I am actually going to wrap up here because I got to go back to the echo lab. We sort of covered all of this. Okay, any burning questions, or you guys can catch me later? Yep.
So how convincing is the evidence that increased calcium?
That's convincing. That's pretty, yep. It's pretty convincing, yeah. But we don't understand, what exactly that means, and there's theories for that.
Is it possible that calcium is protective only?
That's what we are starting to, that's one of the hypotheses, trying to explain it. But again, like I said, it depends on the kind of calcium. Right. But this is all sort of still research-based. Maybe Jeremy will find out for us one day.
Thanks, Prab. Thank you.
Take the box.
I think it was very nice of people, especially coming here.
When you
Oh, yeah. Actually, the protocol.
Can you walk with me? Okay.
Literally.